morning everyone. So today I will be talking about phosphate balance in dental health, how phosphate is important for our oral health, and what all disease conditions and comorbidities will be there in the body when phosphate is present. So coming to the introduction to the phosphate metabolism. First of all, why physiologically it is significant. So it is forming a very important role in the structural formation, a fundamental component of hydroxyapatite, a component of the crystals of the teeth. So it is having also cellular functions such as it participates in the energy metabolism, and that is in the formation of ATP, ADP complexes and nucleic acids, DNA and RNA structures. It is also acting as a buffering agent which will maintain the acid-base balance in the body. So coming on to the body distribution, how the phosphate is distributed throughout the body. So it is 85% is mineralized in the tissues of bone and the dental hard tissues, 14% in the soft tissues, and the extracellular fluid, which will be a small component only, but it is highly and tightly regulated to form the ECM matrix. So coming to the second phase, how the phosphate metabolism is regulated by, first of all, by hormonal regulation by parathyroid hormone. So it is secreted in response to the low serum calcium levels, and it will increase the renal excretion of phosphate, which in turn will stimulate the 1-alpha hydroxylase in kidney, which in turn will enhance the vitamin D function, that is its active form of vitamin D, calcitriol. It will in turn increase the intestinal absorption of phosphate in the body, which will promote renal reabsorption of phosphate, and how this is absorbed in the body through hormonal regulation. And then it overall it enhances the bone mineralization, maintaining the calcium proper phosphate calcium phosphate ratio. Second comes through the fibroblast growth factor 23. It is secreted by the osteocytes in response to high phosphate. Decreased phosphate reabsorption in the proximal renal tubules takes place, which in turn inhibits the 1-alpha hydroxylase, which reduces the calcitriol synthesis. And thirdly, through the clock protein, it will act as a co-receptor for FGF3, which will be expressed primarily in the renal tissues, as I already talked. It modulates in the aging mechanisms, mineral metabolism and phosphate balance in whole in the body. So coming to the phosphate's role in the tooth development and maintenance, first of all, it will play an important role in odontogenesis in the ameloblast and odontoblast. The ameloblast and odontoblast require phosphate-rich environment for the enamel and the dentin matrix component deposition. It is critical during enamel maturation also. It will mainly control the crystal elongation of the enamel and the packing size structures in the teeth. Second phase, mineral phase in teeth. Enamel, as we say, as we already know, 96% is the mineral content, predominantly hydroxyapatite, so it will be found in conjugation with it. Dentin, 70% mineral content. It will be found in the collagen-rich base in the complex, and cementum, 45 to 50% mineralized tissue anchoring the periodontal ligament. How the phosphate is present in saliva, coming to the salivary component, in the form of inorganic phosphate as a buffer alongside the bicarbonates present, helps in maintaining a supersaturated environment for calcium phosphate synthesis, prevents demineralization of teeth and supports natural mineralization process in various enamel lesions. So coming to the imbalances in the body. First of all, we will see the oral manifestations when phosphate is imbalanced in the body. First disease is hypophosphatemia, in which there will be decreased serum phosphate levels. Coming to the etiology, first of all, it is hereditary, which is X-linked. Because of the mutation in this PEG gene. I will be talking about this PEG gene in my journal club, how it is linked to hypophosphatemia. So how second comes acquired conditions. In acquired conditions where we will be having dietary changes and malabsorption syndromes will develop, alcohol abuse, oncogenic osteomalacia. So how we will find that phosphate is imbalanced? Through dental findings, spontaneous periapical abscesses will be there, thin dentine will be there, enamel hypoplasia and delayed tooth eruptions will be there, enlarged pulp chamber will be a most common feature, and taurodont teeth will be there, defective cementogenesis will be there. Coming to the second one, the increased serum phosphate level, that is hyperphosphatemia. If the etiology is advanced chronic kidney disease, excessive dietary phosphate intake through processed foods and artificial foods, colas and beverages. Dental consequences, disturbance in the normal calcium phosphate ratio leading to hypocalcemia, ectopic and calcifications in the soft and the hard tissues, risk of delayed tooth development in children aging as a whole. So coming to the systemic disorders involving the phosphate metabolism. So coming to the X-linked phosphatemia, rickets, that is XLH, it is a mutation in the PEX gene that will have increased FGF23 activity, which will have the renal, which will impair the renal phosphate reabsorption in the DCT, in which we will see the oral signs such as multiple abscesses will be there throughout the bodies, throughout the oral cavity without caries. Increased periodontal disease susceptibility will be there. Coming to the second one, tumor-induced osteomalacia, that is TIO. In this, it is a rare mesenchymal tissue in which the FGF, that is secreted FGF23, will in turn cause low serum phosphate level, muscle weakness as a whole, bone pain in general, and dental effects of this systemic disease include soft enamel, very fragile, tooth will be prone to fractures, early tooth loss in the milk teeth, and also chronic kidney disease, the third one. In this, FGF levels are persistently elevated beyond normal, which will lead to renal osteodystrophy, and oral findings will be delayed reduction, enamel hypoplasia, uremic stomatitis, and increased prevalence to periodontitis. So coming to the clinical implications for dental practice, how we will find it out? Through proper diagnosis first of all. So we have to take proper history of any significant bone pain, comorbidities, growth and muscle weakness if it is there. Screen serum phosphate, calcium and vitamin D through the panoramic radiography, and it will show the dental changes, the thickened dentine, also the enlarged pulp chambers which will be indicative for the taurodontism cases will be seen through the radiography, and delayed root formation will be there. Prevention and restorative management, how we will manage through topical remineralization agents, and also the use of casein phospholipeptide amorphous calcium phosphate, that's CPP, ACP, and also the use of fluoride and phosphate complexes in the form of a dual release toothpaste, and use of non-invasive procedures for salivary phosphate testing, which is an emerging trend in the future of research in this area. And also they will be having the interdisciplinary collaboration of all the specialities of dentistry, so that we can get a proper diagnostic treatment for the patients of this kind of category. So coming to the recent advances and research trends, where are the recent research findings going on in this prospect? So innovations in the Borosumab monoclonal antibody agent against FGF3 research has been going on. It is approved for the X-linked hypophosphatemia treatments. Biomimetic scaffolds have been developed for enamel regeneration using phosphate-based nanomaterials, specifically the CPPA, CP, and engineered salivary diagnostics, as I already told, is for phosphohemostasis is going into play. What will be the future aspects? We can develop phosphate-responsive dental materials as a part of the bio research project. Predict genomic tools used with the help of machine learning for the early detection of hypophosphatemia disorders, and also there will be a role of gut microbiota, how the gut microbiota and the symbiosis and the dysbiosis is affecting this. Research is going on in this phase already. So coming to the conclusion, so phosphate balance is very much important for the oral and the overall oral and the systemic health conditions. Disruptions lead to various systemic and oral manifestations, which will be requiring therapeutic implications, and understanding the molecular mechanisms behind it and the genetical control will play a holistic development, so that we can give new responses and therapies.